Hi, my name is Janice Karen. I'm the Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. If you'll go to the next slide, we'll go ahead and get started with the update. So the Better Identity Coalition has released a set of 5 initiatives that it thinks would greatly improve identity services, particularly online. They go into a lot of detail for each of them. It's a really good document, but the 5 areas that they basically are suggesting are having next generation identity proofing and verification systems, changing the way we use social security numbers to go back to the way they were originally intended to be used, which is solely as an identifier and not as an authenticator or a way to prove that you are who you are. Also promoting and prioritizing stronger authentication by moving away from passwords, pursuing international standards for identity systems, including coordinating with some European and other global efforts in that area, and then also educating the public about better solutions. So as I mentioned, this paper goes into a lot more detail about these and about why some of these initiatives are what they're recommending, and I highly recommend reading it. You can find a link there. Any comments or questions about that? All right, moving on to the next one then. Excuse me. So the CMS Innovation Center, this is CMMI. They have released an update on their strategy implementation. This is the strategy that they originally released about a year ago. And there are 5 strategic goals that it's all sort of framed around. They are driving accountable care, advancing health equity, supporting innovation, addressing affordability, and partnering to achieve transformation. The update provides both some things that they've achieved in the last year, which I've highlighted a few of these here on the slide, as well as a bit of a roadmap for what they're going to continue doing into the future. So for an example, I'm not going to go through all of the specifics, but under advancing health equity, they talked about enhanced data collection and new social needs screenings, and also providing new incentives and having new requirements for organizations they work with to have their own equity plans. And so they had more or less information about some of them. They've done more than others, but it was really interesting to see sort of their view of what they've achieved and also what they're planning to do in the near future. Any comments or thoughts or questions there? All right, moving on to the next item. ONC has released a report on the patient access to data in hospitals with 2021 data. Some of the highlights there include that about 70% of hospitals have enabled patients to access their health information via software applications, and they stress this is both mobile and other types of applications. 50% of more than 50% of hospitals supported some level or some type of FHIR-based patient access. This is not necessarily FHIR Rev 4. This is not necessarily the type of access that new regulations will give them access to, but something. And they also mentioned that more than 80% of hospitals allowed patients to view clinical notes in portals. Realistically, you know, that sounds like a pretty good number, but generally speaking, having at least the clinical notes that are within USCDI version 1 in the portal is considered part of not information blocking. So although there's no specific requirement that says every single item must be in the portal immediately, the general consensus is that items are supposed to get put in the portal as soon as they're available. So that 80% sounds good in one hand. On the other hand, it might be a little bit lower than it should be.
And I assume that's 80% of the 70%. Right? 70% have enabled software access.
Well, I actually assumed that was not their portal, but through like mobile applications or applications that they could install. That was, so I took those as being separate groups.
The 80% is also only clinical notes, right? It
Right.
doesn't include the
That's right.
granular clinical data. So even, having notes available does not necessarily mean these hospitals are in compliance with the information blocking provision.
That's
right?
correct. But the note, but clinical notes themselves, at least under 8 categories, are part of USCDI version 1, when that was the only requirement. And now, of course, all clinical notes are part of the electronic health information set that falls under information blocking. So, so that's an interesting tidbit. So any further thoughts or comments here?
Well, one comment or question I would have is it your sense, Janice, that while 70% of hospitals have enabled patients to access their health information via software applications, that doesn't necessarily mean that these are either FHIR compliant exchanges between patients and hospitals, or that the health information that patients are able to access is necessarily complete? Is that?
That's correct.
Okay.
In fact, you can just look at it that the number went down when you're talking about some type of, even any level of FHIR support.
Right.
And I would bet money that 50% is not having full FHIR version for US core and some useful implementation guides available. Anyone else have any thoughts or comments there? All right, let's go on to the next one. This is interesting. So this was announced last week, I guess a week and a half ago now. And there's not a ton of details available, but SNOMED and LOINC announced that they're going to be working more closely together in the future. And their goals are to reduce current and potential future duplication and facilitate the use and interoperability of SNOMED and LOINC. And one of the things they talk about is supporting implementation that mix and match the use of the 2 code sets. But they also talk about what they're calling a LOINC extension, which actually includes both SNOMED and LOINC codes for all of the concepts where where there's some sort of where they map up, and then having joint distribution of LOINC and SNOMED content and an annual joint meeting. Now, this is interesting because obviously it's related to the idea of code mapping, and going between SNOMED and LOINC in either direction is really important for interoperability and for meeting some of the regulations. A lot of data in USCDI specifies either LOINC or SNOMED, but that same data might be stored in the other system, wherever it's originating. However, regardless of what they're planning to do, this is literally just an announcement of intent at this point in time. Who knows how long it will take for anything to come of this, or for this to actually come to fruition in any useful way. But still, it's promising that they're thinking about it, and you can find a press release about it there. Anyone want to comment further? Or
So does this mean that they will become the authority for how to map the code sets together?
Most likely, if they follow through with what they're talking about at some point in the future, they should, just for that particular mapping. But I think we need to know a little bit more. And again, there's no time frame. We don't know if we're talking 3 years from now, 5 years from now, or 10 years from now, having something that's useful. I mean, obviously, it would be really nice to have it very soon, but it's the early stages.
Do we have any insight, Janice, into how these organizations go about doing this kind of work? Is this, the proverbial smoke-filled room, or do they employ technology to help them? Is this, a highly manual, quasi-manuals, reasonably automated, highly automated? How do they sort of go about this process?
They didn't specify. I got the impression that at least initially it would be closer to the smoke-filled room than anything that's automated, but I assume that there would be some level of automation implied for getting initial checklists of things that need to be considered or looked at, or also for validation. And so I assume there will be some level of automation built into the process at some point, but I think that that's certainly not going to be the bulk of what they have mentioned intending to do so far. But I really don't know for certain. Any other comments or thoughts here?
We've talked about this before, Janice, that currently they map to the tune of what, 8,000 codes?
So there is an existing quote unquote industry standard mapping between SNOMED and LOINC that was worked on by either one of the two organizations, I'm not sure which off the top of my head, that includes about 8,000 concepts. They are predominantly laboratory and vital sign data. And it was discontinued in 2017 with a note that it should not be relied on for to be accurate, and it hasn't been updated since. So that's the current state of what's out there in terms of anything that could be considered an industry standard effort or an official effort from one of the standards groups.
Could you comment on the approach to doing, developing these clinical vocabularies has been focused on historically, sort of a deep review by clinical experts of, particular clinical scenarios, and then the assignment of, of standard codes, domains, however they organize themselves. But we're moving into, an age where machine learning and natural language processing could well do a better job, or not, I guess is at the heart of my question, than humans attempting to do this in the traditional smoke-filled room approach. Could you comment on that and what your thoughts are about how AI and, its specific manifestations for this kind of work might have an impact?
Yeah, I think it's an interesting thing. I think there's definitely a role for AI or automation, some type of algorithmic approach. I do think that you have to be careful initially about validation and ensuring that the data is accurate enough. There's different ways that you can introduce biases and unintended outputs from an algorithm, and and what you're getting is a probabilistic answer. And so understanding what that means and what type of threshold you're comfortable with accepting as an accurate result is important. And understanding whether or not that's going to be problematic and what the consequences are if there are problems with that, and how to mitigate those as much as possible. So I think it's definitely something that needs to be explored. Is it the way that every code set on the planet is going to be developed 6 months from now? No. Is it a tool that could be useful now? Probably. But with careful application and thought.
Well, does the question not remain that even when humans assign these codes to clinical content in the electronic medical record, there's a high degree of uncertainty as to inter-rater reliability, right?
Well,
five
yep.
people in a room given the same clinical content, might assign different Loink or SNOMED codes to that. Is that not a possibility also?
That's absolutely true as well. You know, there's human error, there's human differences. So I think that the most important thing is, regardless of what mechanism is used, that there's a consistent agreement about what specific codes mean and how they should be applied. And then it's up to the people using them to make the best effort to apply them that way, and up to the people trying to do things like mapping them to do the best mapping possible. And again, which mechanisms or what combination or percentage of manual versus automated works best is something that has to be carefully looked at, tested, validated. And I think that that's probably
Yeah,
the
Dennis,
yes.
some of this mapping work was done quite a few years back by loink.org regarding Loink to SNOMED. I recall looking at some of it for some purpose.
That's right. Oh, I'm sorry. Go ahead. I didn't mean to interrupt you.
No. So I was just wondering where it went, or was that completed or not?
Yeah, so that was the mapping that I was talking about that had 8,000 concepts. That
Okay.
was discontinued in 2017.
Okay.
I didn't remember if it was done by the Loink folks or the SNOMED folks.
It was the Loink
so-
folks, yeah.
Yeah, so it wasn't completed,
Mhm.
and it had a very narrow scope, and they've
Okay.
basically disavowed it since.
Okay.
So yeah, I think that there will have to be some automation, and certainly if you're looking to do this at scale, and looking to do it in a time frame that's useful, then you're gonna have to, make some jumps into automation and make some jumps into doing that. But you need to understand and accept the risks and mitigate for those in the way that you use the system.
Mhm.
It seems that to me at least, that if instead of getting together and trying to figure out how to map their legacy codes to each other, that it would be a better, and perhaps this is something MHDC can play a role in writing a letter to these organizations. But what are the features of a good AI algorithm that would be necessary in order to not only do a mapping, but to validate that mapping via comparison to manual mapping? They're not going to get from 8,000 to 500,000 by doing this, manually. So having some visibility into how they go about employing some level of, machine learning, natural language processing, identifying the features that comprise a code, the dimensions of a code, how it's categorized, whatever their sort of topology is, and investing time in coming up with an algorithm that has external validation would be a much better investment of their time than trying to
Where do you get the data from? I mean,
boil the ocean.
Yeah.
It's like we're going to go get together and boil the ocean. It sounds daunting, to say the least.
But we do need to get some good historical data to be able to create the AI algorithm.
We have to talk to John Halemka at Mayo and say, we want to look at your 200 million records and see what we can figure out there.
Yeah, I think it's doable if they're willing to give it.
Yeah, so we'll see what comes of it. We'll see what direction they go in. They really did not provide a lot of details. I do think that you made some really excellent points about, about automation and using AI and figuring out algorithms that are effective and how to validate them. And we'll see where they go with this. Let's move on. So there are a series of new IDR guidance for No Surprises Act stuff. The first one is for IDR entities, these are the people who manage the dispute and decide who should win, basically. And you may remember that we looked at some guidance a few weeks ago, maybe a month ago, on this, and this is kind of an expanded version of that guidance. And this one goes more into the process on timelines and requirements and fees. And you can see that it kind of discusses the process from start to finish, even the pieces that are not that might precede actually having an IDR entity, just so that entities kind of understand what they should expect to have already happened. And so it's just kind of an overview of the process as a whole, with a focus on the IDR. And the IDR, for those of you who may not remember, is independent dispute resolution process. That's part of No Surprises. So this is when the payer and the provider can agree on what they should get paid for out-of-network services. You can find the guidance document at that link. I'm going to go ahead and talk about the next one, and then we can open up because it's really similar. So this is basically the same guidance for the disputing parties. So basically it covers most of the same topics as the previous set of guidance. The main addition is discussion of the federal portal for, excuse me, initiating and maintaining and managing the process as a payer or a provider. And obviously the way that it talks about each of these steps is more focused on the participants. So any questions about those two things? Any comments? All right, let's go ahead and move on to the next piece of IDR guidance, which is fee guidance. So the way that the process is set up, there are two separate and distinct fees. One of them is considered an administrative fee, and one of them is a fee for the dispute resolution itself. So the administrative fees are actually paid to the government. Well, they're paid to the entity, but they're sent to the government. And what they're meant to do is to cover the expenses of running the independent dispute resolution process, as opposed to the costs of taking care of an individual disputes. So this is a small fee that both the payer and the provider pay for every dispute that they're involved in. And they're supposed to basically adjust it every year based on the data from the previous year, so that they can kind of estimate what they need to cover the costs. They didn't have enough data from 2022 in the time frame. The portal opened in April. They probably made this decision in September, given when they put this out. Even if it was in October, it was only a few months worth of data. And so they're just leaving it alone and leaving it at the $50 fee that's in place now. Excuse me. However, the fees that are paid to the entity that's doing the determination have been increased, and they also made an interesting adjustment there. So the way this works is both parties, it's not technically an escrow, but it's kind of like an escrow process. Both parties pay the fee, and then the whoever wins the judgment gets their fee refunded, and then the fee from the other person, the other side of the dispute, gets remanded and basically is allowed to be usable by the IDR entity. So the way that the fees traditionally work is that there's a set range that each entity is allowed to charge, and there's a range for having one item or service being disputed. And you can see that that went from a range of 200 to 500 to a range of 200 to 700. And then there's also a fee for batch disputes, and that went from 268 to 680 up to 268 to 938. But they also made another change. One of the frequent complaints is that the amount that they can charge for the dispute was not dependent on the number of items that were being adjudicated. And so they've actually excuse me, set some ranges where you can, so that range, that 268 to 938 is considered 100% of the maximum allowed fee. So the 938 is 100% of the maximum allowed fee. And if you're doing 2 to 20 items, that's all you're allowed to charge. 21 to 50, you can charge 110%. 51 to 80, you can charge 120% of that. And then 81 items or more, you can charge 130% of the maximum, and that's where it maxes out. So it's allowing a little bit of leeway to increase the fees if you have to adjudicate a larger number of items. Now, in theory, the items are all identical, so it should be one judgment for all of them, but it's not. They still have to, there's still some extra administration for ensuring that they're all valid and that they're all viable and they all belong in the same batch and stuff like that. So as the number of items increase, the amount of that administrative extra increases. So it's not unreasonable. Any comments or thoughts here? All right, let's move on then. So this is something that we missed because it was not widely advertised. There is a draft TUFCA, what they're calling a facilitated fire implementation guide. It was actually released on October 7th, but it just came to our attention. It wasn't even mentioned at the TUFCA session at WEDI, even though fire was discussed a bit. So the thing is that even though it's called an implementation guide, it's not a traditional implementation guide in the fire sense of the word. It's really very similar to TUFCA standard operating procedures documents. It outlines policy, technical, and process requirements for using fire. And it covers a bunch of specific areas, what you're required to do for provenance, patient matching, error handling, versioning, token expiration, and a few others. And we'll probably look at some of that in more detail later. But it also talks about 2 use cases that are allowed. One is they're calling patient discovery, authentication, and authorization. That's essentially clinical data exchange. And then the other one they're calling information queries. And that's basically discovery of fire capabilities and support. And let's go on. This continued on the next slide. So if we'll go to the next slide. So they also talk about infrastructure requirements. So they talk about endpoint and endpoint discovery. In particular, they talk about requirements around having a fire capability statement, which is how the fire way of determining what a particular fire service supports. They also talk about authentication requirements, TUFCA certificates, which I'll have to research further later. The one area where they go into a lot of technical detail is the client registration process. They have a rather extended technical description of APIs for client registration. And then they also talk briefly about fire support requirements and recommendations. And so they're going to require Fire version 4 and US Core version 4, which is the US CDI version 1 equivalent. So basically, that's what you need to support all of the current regulations around fire and US CDI. They also say that you should support, should means that it's optional but recommended. US Core version 5, which I believe maps to US CDI version 2, bulk fire, something called mobile access to documents, which I've actually not heard of before, possibly because we don't look at document exchange as opposed to exchanging objects very often, structured data, and also the DaVinci PDEX implementation guide. So those are not required, they're recommendations, and you can obviously support other things as well. So you can find their implementation guide there. And again, I'm sure that we'll be returning to this after we've had a chance to look at it in more detail. Any comments, questions, thoughts here? All
One
right.
question,
go ahead.
Janice, is there does still seem to be not unexpectedly, you know, the DaVinci PDEX, that's the PDEX is the patient data exchange.
It's actually technically it's the payer data exchange,
Payer data
but it's
exchange.
focused
Okay.
on what's needed to do patient access APIs and payer-to-payer data exchange.
Okay, so
So
payers are being envisioned as being part of TEFCA exchange in some capacity, given these
yeah, but
developments.
I got the impression that it was really designed to manage the clinical data exchange more than anything else. But I have
Okay.
not read this in full detail. And, I do think that certainly, there is a discussion of TEFCA having support for providers, for payers, for patient substitutes, what they're calling the individual access. I don't remember what that S stands for. IAS meaning apps that can get data to patients. So at least at the level of what's being discussed, all three of those groups are supported in some way. As you've implied, there generally is a more provider focused tilt to a lot of what TEFCA does, and it is not clear whether or how much of that will change in this environment.
Thank you.
Yep. Anyone have anything else? All right, let's move on. So this is an update from something we talked about maybe a month or so ago. We had the White House released a bunch of proposed security initiatives. And one of the things that they talked about without a lot of detail was some type of security label that could be put on products or maybe virtually on services. So this is not official. This is a press article that provides a bunch more detail, some of which is not confirmed and some of which was sort of leaked. So from some type of official source, but not official. And so there was more available if you go look at the full article, but some of the things that they talked about putting on the label are the amount of information that's collected on consumers using the device, whether its data is encrypted, and its interoperability with other products. They also had a sample label, which had a lot more information than what they talked about. So it was unclear how that would be adopted and if everything on that label would be something that would be part of this initiative. But supposedly they're looking to start this on an optional level in the spring of 2023. And the first things that they're targeting are routers and connected cameras. And it's not, and possibly other what they're calling vulnerable products. And it's not really clear how that will evolve and or what type of uptake there will be from an optional programming. The other thing that was in this article, though, which is not the same but somewhat related, is they also talked about some international standards around giving 1 to 4 star ratings to medical devices on their security practices. And so there was some discussion about the US maybe not taking that program verbatim, but adopting elements of it and trying to be somewhat aligned to it so that the stars mean similar things or something of that sort. And there wasn't a ton of information about that either, but that was interesting and something that might affect us directly. So something to keep an eye out for. So if you're interested in this, you can go look at that article, see the sample label and some more information. Any comments or thoughts there? All right, moving on. So also just an update from last week. We confirmed that we had a question around whether you had to include specific prior authorization information on advanced explanation of benefits. And as we discussed last week, you're required to put a disclaimer, but not provide the specific prior authorization info. So you don't have to reflect whether one has been granted or any pricing differences as to whether what would be charged if there is a PA versus not a PA. But you do have to tell the patient or member in this case, whether their coverage that is outlined in the AEOB is subject to any type of medical management technique, not just prior authorization, but some type of review process, step therapy, first fail protocols, or other things that are in that group of things. So the other thing that we discovered when we were double checking this is that the current No Surprises RFI that's out also sort of touches on this subject a little bit. And so it asks for feedback or input on whether there could or should be some future alignment between the data exchange that's set up for getting good faith estimate data and those that are set up for prior authorization. So this is mostly aimed at the actual clinical and administrative data exchange and not the AOB itself, but it seemed to me like the way that this was presented, it could lead to some additional requirements around including more prior authorization information on EOBs in future regulations, since the necessary data would presumably be coming together or similar, because if they're trying to align them, then in theory, when you have all the data you need for your AEOB, you have all the data that you need to make the prior authorization decision as well. But that's me speculating. So any thoughts or comments on any of that? Does that address the question from last week for the person who asked it?
Janice, thanks. I mean, there's a separate work going on with prior auth, and that's why I was trying to understand how they were the two were connected, or if they were. And
yeah, no, totally makes sense.
Yeah.
All right. Well, that concludes our quick updates. I hope you learned a lot from the quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That's dgc@mahealthdata.org. Thank you very much.